Hello, also from my side, I'm really excited to share again 4 cases tonight. And we have the privilege to have 4 great speakers who are willing to share their case and their experience. And I think we also have an exciting panel to discuss. The goal, of course, is to raise thoughts, to exchange thoughts, and hopefully that we can all learn just looking at the cases. And now I'm very happy that Tom DeLaney chose to start, and please start with your case. Thank you so much.
Thank you, Bruno. Right, so the case I'm presenting is a 34-year-old man who presented with pain in the left hip. He saw an orthopedic surgeon who obtained a pelvic x-ray that showed a destructive lesion with a cartilaginous matrix in the left proximal femur. An MRI showed a large bone marrow replacing lesion in the left femur, dark on T1, bright on T2, with robust but heterogeneous uptake of contrast. There was violation of the femoral cortex and a soft tissue mass infiltrating into the surrounding musculature. And here is the MRI scan. You can see the contrast between the tumor and the femoral head here, with evidence of extraosseous tumor seen both on the coronal and the axial MRI. All right, next step.
So CT-directed core needle biopsy, 67%, and then each some 15% ultrasound-guided core needle biopsy and open biopsy, and 6% fine needle aspiration. So you can go on.
Yeah, I think most of us would prefer to start with a CT-directed core biopsy for soft tissue sarcomas. Like many people do use ultrasound-guided biopsies, but for bone tumors, you obviously see bone better on CT, and our pathologists like to get a core rather than a fine needle aspiration for most primary tumors. So a CT-directed biopsy was scheduled. The patient was instructed to avoid any activities that would cause mechanical or functional pain within the thigh, and was instructed to perform only toe touch weight bearing on that left lower extremity. The CT-directed biopsy was done. It showed a dedifferentiated chondrosarcoma, high grade, grade 3 of 3, and staging workup consisting of CT, chest, abdomen, pelvis, and bone scan were scheduled. You can see the biopsy needle here on CT within the lesion. Several days after the biopsy, the patient reported a pop in his left hip while turning in bed, with the resulting of worsening hip pain. Plain radiographs that I'll show demonstrated a new pathologic fracture of the femur, and the patient was admitted to the hospital. The AP radiograph here shows clearly the cortical break with some modest displacement, and the CT scan demonstrates the fracture as well as some fluid and blood products adjacent to the tumor. A new MRI was done as well, which confirmed the pathologic fracture through the tumor. The tumor extended from the level of the junction of the femoral head and neck down through the fracture site, and from the fracture site for another 11 centimeters distally. As mentioned, there was a non-enhancing fluid and blood products at the fracture site, as well as surrounding edema and enhancement of the muscles surrounding the fracture that you can see quite dramatically on the post-gadolinium axial scan here. And you can see the displacement between the more proximal and the more distal femur, with tumor in the marrow both above and below the fracture. A bone scan was done that confirmed abnormal tracer activity in the left proximal femur, with no evidence of distant osseous metastases. CT scans of the chest, abdomen, and pelvis were done, and this revealed right lower lobe pulmonary parenchymal masses, as well as a small right pleural effusion, as well as the expansile mass in the left proximal femur and the pathologic fracture. And the bone scan is shown here with the activity in the left proximal femur. And here's the CT scan. One can, as mentioned, see the small pleural effusion as well as parenchymal masses in the right lung. And next to audience poll question, the next step.
So the results are 53% resection with hemiarthroplasty, then some 20% each neoadjuvant chemotherapy and video-assisted thoracoscopy for nodule and pleural biopsies, and 11% neoadjuvant radiotherapy.
In my experience, I've always found it very helpful to confirm before therapy starts, wherever possible, if indeed there is metastatic disease. And so this patient underwent a video-assisted thoracoscopy for resection of the dominant nodule on the right lung, as well as pleural biopsies. And interestingly, the pathology from the right lung showed pulmonary infarct without evidence of tumor, and the right pleural biopsy was also negative, so that going forward, the plan was to anticoagulate the patient at the appropriate time. All right, next step at this point. So we've confirmed the primary diagnosis. We've established no evidence of metastatic disease.
So here, well, I think that's the same as before, again. Resection with hemiarthroplasty, 67%. Then each 14% neoadjuvant chemotherapy and neoadjuvant radiation therapy, and 5% neoadjuvant chemoradiation.
Because of the pathologic fracture, my orthopedic oncology colleague Eric Henderson, who couldn't be here today, his wife are expecting another baby. In any case, went ahead with the resection with hemiarthroplasty. And here are the postoperative radiographs with femoral replacement and with preservation of the distal femur. Darcy Kerr, my pathology colleague, provided this nice picture of the resection specimen. You can see the tumor with the pathologic fracture, as well as tumor and blood products extending into the surrounding musculature. The pathology indeed confirmed dedifferentiated chondrosarcoma with tumor both in the bone and soft tissue extension with the pathologic fracture. The tumor was over 17 centimeters in size. Tumor necrosis was seen 25%, a high mitotic rate. The resection margins were indeed negative, with the closest margin 0.1 centimeters. No lymphavascular invasion was noted. These are the histology of the tumor with a low power and a high power view, showing the highly pleomorphic tumor cells with multiple mitoses. And I'm not, at least in the high power, I'm not seeing any obvious cartilaginous matrix. Often you see these tumors juxtaposed to a lower grade chondrosarcoma. The proximal resection margin, just showing the resection margin here, negative with a cuff of muscle. All right, at this point, the tumor has been resected. What would the audience like to do in terms of the next step for treatment?
So each 35% adjuvant radiation therapy and observation, 29% adjuvant chemotherapy, and 0% adjuvant immunotherapy.
So I think, as with many of our uncommon tumors, we have less data than we would like. We know this tumor has a miserable prognosis, and the major failure pattern is distant. There are some recent data that I will show that at least are somewhat encouraging in terms of adjuvant or neoadjuvant chemotherapy. So that was the recommendation from our group, was to start with adjuvant chemotherapy, and the choice of a regimen. My colleague from medical oncology, Garrett Wasp, elected to use cisplatin and adriamycin. And if there's no evidence of tumor dissemination after chemotherapy, we'll consider adjuvant radiation to the thigh because of the prior pathologic fracture and the clear fluid and blood extending into the muscle around the fracture site. The patient was started on apixaban for his pulmonary embolus. And I thought I'd just make a couple of brief comments about dedifferentiated chondrosarcoma, cite a couple of articles, and we can open it up for discussion. So it's an uncommon tumor, and Chondrosarcomas, incidence of about 2.85 million per million per year. Dedifferentiation occurs in about 15% of all chondrosarcomas. As I mentioned earlier, these are high-grade tumors with a typical bimorphic histologic appearance, with areas of lower-grade chondrosarcoma adjacent to the high-grade sarcoma. Surgery is the main option for treatment, but metastases frequently develop around the time of surgery or evolve after surgery. Hence, the prognosis is poor and the management can be challenging. Rob Grimer collected data that was published in 2007 from 9 European centers, and it was a review of 337 patients collected over a 30-year period. The median age 59, slight male predominance, average size of these tumors over 10 centimeters. And as in our patient, the most common site is the femur with the pelvis, the second most common site. Interestingly, almost a third of patients with a long bone tumor had a pathologic fracture, so a significant problem with this disease. About 2/3 of the patients had no metastases at diagnosis, and about a third of them received chemotherapy. And among those getting chemotherapy, and about a third it was neoadjuvant, and 2/3 postoperative adjuvant chemotherapy, and a slightly higher proportion of patients younger than 60 had chemotherapy. I think the takeaway from this study in terms of prognosis is that the prognosis is quite poor for these patients. 28% at 10 years, and in fact, other series I've seen have had substantially worse survival figures than this. In terms of risk factors for poor prognosis, or even more poor prognosis in a multivariate model where patients with a pathologic fracture, a pelvic primary site, older age at diagnosis, and positive margins. At least in the choice of patients here that was who received chemotherapy, it didn't appear to affect the outcome, but it was a minority of patients who received chemotherapy. About 15% of patients sustained a local recurrence rate, and it was a lower rate in patients who had a radical excision compared to those who had a marginal or intralesional resection. And they didn't identify an apparent risk of higher risk of local recurrence in patients with pathologic fracture, but maybe a situation of competing odds where those patients are substantially a higher risk for metastatic disease. They may have developed metastatic disease before they developed local recurrence. I'm just going to close with a recent paper that was presented at CTOS a couple of years ago and published last year. And this is looking at outcome in dedifferentiated chondrosarcomas in patients who were in the Eurobus study, so patients with bone tumors over 40. And it was a prospective study that accrued 57 patients, and it was designed to evaluate the activity in chemotherapy in patients with high-grade spindle cell or pleomorphic bone sarcomas over 40. And patients received either 3 cycles of neoadjuvant chemotherapy and 6 cycles of postoperative adjuvant chemotherapy, or they underwent resection and 9 cycles of postoperative chemotherapy. The chemotherapy is shown here, adriamycin, ifosfamide, and cisplatin. And if patients had a poor histologic response, they added methotrexate post-op, and 6 of the patients who received chemotherapy indeed received methotrexate. Of the 57 patients who received chemo, 21 were able to receive the full 9 courses, and 40 had at least 6 or more cycles. Certainly aggressive chemo, which you can see in terms of the delays. About 3/4 of patients had delays of at least 1 cycle. And there was at least 1 grade 3-4% in the majority of patients, but they had no grade 5 toxicity. Of the 57 patients, 60% had no metastases at diagnosis, and 54 of the 57 patients underwent resection. 33 had a primary resection, and 21 had resection after neoadjuvant chemotherapy. Of those 21 patients, 19 were able to have their pathologic response assessed, and it was good in only 4, and 15 had a poor histologic response. Interestingly, they evaluated the effect of patients who could have a surgical complete response, which they defined as a margin negative resection of the primary and any metastatic disease, and that was achieved in about 2/3.
So I think, Tom, if we take the liberty to interrupt here. Thanks so much for your great presentation. Any comments just up front? Or let's say first let's say regarding pathologist, is there any comment from the pathologist side regarding diagnosis? Is it complete? Do you think there are some new avenues we have to bring in?
Well, the diagnosis of the differentiated chondrosarcoma may be challenging if we just have the undifferentiated portion. So if we don't have a clinical correlation or imaging correlation with the chondrogenic part, well, we can end up with pleomorphic sarcoma and then kind of discuss the possibility of the differentiated chondrosarcoma. And well, IDH mutation is not present in all cases, so sometimes we end up not having the definitive diagnosis of the differentiated chondrosarcoma. Can also present, you know, histologically, so the differentiated portion can be presented as osteosarcoma, so it may be kind of confusing if the biopsy is not from the right spot. And my other remark is concerning the metastatic disease in the lung. So sometimes it's worth to check the histology, as you know, confirm it on the slides that it's not infarction or lymph node.
Bernadette, what do you think?
I think there is nothing to add. I assume that they had a well-differentiated chondrosarcoma component before making this diagnosis. And I assume if you look very careful to the macroscopy of this tumor, there might be one foci which is more like, which might be a better differentiated chondrosarcoma part in the distal part of the resection specimen.
Mm.
But for us, we do this diagnosis if we have both components, the dedifferentiated component as well as the well-differentiated component, or if we have the IDH mutations. Otherwise, we will have the diagnosis of pleomorphic sarcoma.
Another question, there was a pathological fracture, and this is directed to the orthopedic surgeons. What's your standard approach, let's say, in a DDIF chondrosarcoma pathologic fracture? I mean, we are a little bit torn, right? What are you doing in Japan and in Austria, in the Netherlands, and in Germany? Shintaro, do you want to start?
Yes. Yeah. Thank you very much for Tom to present your surprising report. So I have two very impressive points. One is I understand that the lung region must be a metastasis of the DLF control, but that is not. That's very impressive. And number two is the very good hand on the musculoskeletal orthopedic surgeon for this study, this patient. They achieved a wide resection, even in a very narrow margin, but they completed the resection and do the limb salvage without losing the limb. So surprising for me. But maybe I decide to do the amputation, hip amputation for this patient to achieve the well local control.
Yeah, what do you think?
I think our surgeons have preferred to try to avoid amputation, particularly in these patients with dedifferentiated chondrosarcoma, because their prognosis is so poor. I think it's the kind of thing that anything you can do to do limb salvage, I think, is probably in the best patient's best interest until we have better systemic treatment.
Yeah, if the lung lesion, if the lung lesion is a metastasis, of course I do the best to avoid the amputation, but this time, so it's very difficult to decide. Yeah.
What's the practice in Austria and Leiden?
Well, a lot of it has been said already. What we found somehow helpful from times to times is that you put a fixed X in when you have a pathological fracture, especially in the proximal femur. That works well when you do a hip joint, a spanning fixator from the ilium to the femur. You gain some time, you gain stability. You can think of your options for neoadjuvant treatment and then go on with a resection as the fracture and especially the hematoma is then more consolidated. I mean, it's utterly disastrous situation, but that can be helpful if you have a little bit of time, a little bit of more consolidation of that acute hematoma around the fracture.
Yeah, it's balancing quality of life and outcome. I understand and I acknowledge the bad prognosis of DDIF chondrosarcoma, especially in elderly patients, but it's not that we don't all have patients with DDIF chondrosarcomas that have survived. So
That's correct.
if you can treat them with a margin and you can cure them, then you may also want to consider not saving the leg. And of course, the lung lesion is pivotal there.
So we need to spend the word, of course, for radiation and medical oncology. So please, I mean, Tom nicely illustrated the most recent literature. And what's your different take on?
Well, I thought we would, our plan was to start with chemotherapy, 6 cycles, and then if the patient has not disseminated at that point, would probably add adjuvant radiation as well because of the pathologic fracture. I think there's less data than we'd like, but I think a high-grade tumor with a pathologic fracture, I think that seems reasonable.
We would do exactly the same than Tom on in Lyon and in France in general, given the young age of the patient, given the specific situation. Actually, we tend to do more neoadjuvant treatment outside the context of a pathological fracture that we have seen in this case. Yeah. We tend to follow the Eurobos protocol. Actually, we are quite convinced.
Yeah.
Yeah, we would certainly also have a low threshold for postoperative radiation, but it's, I think, often case related.
Bruna, any different practice in your geographic area?
No, same here. We are trying to implement our Eurobos as Jaip's saying.
Very good. Well, thank you so much. I think that's awesome. We move on to the next case, and I think it will be great. I want to introduce Jakob from Mannheim, Germany, who has just recently published an exciting merge in diagnostics, and I'm very thankful that you are happy and willing to share with us. And of course, I'm looking forward also then to the discussion. Please, Jens.
I thank you for your invitation, and I'm really sorry this didn't went out the way you wanted at this moment. At least you're seeing me properly right now. And so I was kind of invited to present something or a case regarding some scientific work we did before, and I just decided to bring you what we did because I think it's a quite interesting discussion on functional imaging to improve treatment allocation in soft tissue sarcoma. And most of the work has been done in my former affiliation, which was in Göttingen. It's a comprehensive cancer center there. And then I moved to Mannheim back again. And I want to introduce some of that work to you, which might be interesting for some more discussions. So as we know, just applying like post-operative adjuvant treatment or even neoadjuvant treatment unselectively to patient is not effective in soft tissue sarcoma. But if you stratify patients, for example, with a circulator or with other means, you can have very nice results, and so you can really choose the patients who would have a benefit from pre-op treatment, as you see in this example from a patient with a leiomyosarcoma who was treated with 4 cycles doxa plus ifosfamide, and he had a nice regression, and I can tell you he was resected with a hemicolectomy and a carver replacement, and everything went fine. and the tumor progression about 80% in the tumor. But I won't present that. The most interesting question for me is how to select those patients, because in the presence of being very uncertain in core needle biopsies, in soft tissue sarcoma at least, there have been a couple of cohorts out who said, or who discussed the consistency of pre-op grading by biopsies or resected specimen. And there's from St. Dirk Strauss, and they do a lot of biopsies, and they have a very, very experienced pathologic team, and they reach like 86%. But there are other teams out who said it may range between 30 and 60% or even 90%, depending on what you do. And the difference and the difficulty is, of course, if you take a core needle like that, even if it's 2 millimeters in diameter and 2 centimeters in length, and you hit a tumor like that, you then have a chance to hit any lesion of that, and or any site of that, and then you need to decide what to do with the patient. And you can opt with a grade 2 leiomyosarcoma, for example, what would you do at your place? So that was what we were thinking about, and we have a lot of imaging out there. Most patients in Germany, at least, they get MRIs, and they get MRIs with a lot of features, and it's T1, it's T2, diffusion weight imaging, and then you look at pictures where you can say, okay, you have some information, you may correlate those with what we call mitosis, which you use for FNCLCC grading, which is very useful to differentiate between low and high grade tumors in clinic. So what we try to do is to fuse the two things, the biopsy and the imaging, to look how we can handle that in the pilot study. So the methodology of that pilot trial was to correlate functional imaging and FNCLCC grading, and we did a pre-op standard assessment, including in functional MRI and choosing diffusion weight imaging. I can comment on that later on. And then we did the standard of care resection of the tumors. And then comes what the experiment was. So we took the tumor, and you see that is one example tumor, and we took a lot of biopsies out there, and we left some radio markers inside. You can say we always left like the tip of the pen in the tumor where we took the biopsies, and we took like 3 or 4 biopsies, and then we did a CAT scan of just a specimen. Here's the specimen, here's a CAT scan of that, and I just put some circles around what we left as a marker. You might see it's 1, 2, 3, 4 small marbles inside there, or 3. So we could say where we took the biopsies. So when we had the biopsies, did some grading on these, and then we did fusion imaging on those. So we tried to put this CT image back in the MRI, and I want to show you that in a second, and I hope this works. Right now, it worked a couple minutes ago. So if you look at this picture, it's a short video, and I may stop it at some point. For example, this shows you that if it's a CAT scan of the whole thing after the operation, and then you go back and fuse it. So it does show here CT scan or MRI scan. You go further with a CAT scan, and then you fuse it together with the MRI, see the whole picture. And of course, what it makes is, it does show you where you took the biopsy. You see the biopsy here, or on the arrow line of the CAT scan and the MRI. And then you can say, like, site specifically, what was on the biopsy and what was on your imaging. And that's what we basically did. So I know this is a large graph. This is from 14 patients, and you see we had a lot of histologies because we did it very unselectively with dedifferentiated liposarcomas and oviosarcomas, also with leiomyosarcomas. And I want to go to 2 or 3 cases inside. First case, it's a leiomyosarcoma. It's a grade 2 tumor, and you see one biopsy was grade 2, and the 2 other biopsies was grade 1, and this one also was grade 1. And we also had patients after pre-op irradiation, like this microfibrosarcoma, where it didn't have any grading because it was all necrotic tumor. So that was by chance what we had done. So we can also see that is a graph which shows the correlation of grading, like FNCLC grading, low grade versus high grade, where we decide or may decide for pre-op chemo. And ADC is a apparent diffusion coefficient, which is a parameter of diffusion weight imaging. And so if you have a low value of ADC, it usually says that you have a lot of cells inside. It's more a sign of cell density or material density. If you have a high apparent diffusion coefficient, you have less cells inside, and that may correlate with the grading. And of course, it's a few patients, and this is only a pilot study, but it can show you what is a very interesting, or for me, what's the most interesting case is. You remember I showed you the leiomyosarcoma, a large tumor here, and he had a grade 2 tumor, and indeed this clinically went to chemotherapy at our place because the biopsy was a grade 2 tumor. But we had another biopsy with a grade 1, and if you imagine we do it preoperatively, you could have hit this position. And of course, if you look for all 3 biopsies in the whole tumor for FNCRC criteria, you could say tumor differentiation can be determined by any of these biopsies, and was leiomyosarcoma. And the second is, if you look for tumor necrosis, the tumor didn't have more or less any necrosis, and none of the spots had any necrosis on biopsy. But if you look at mitotic count in all 3 positions of the whole tumor, you see there's a biopsy 2, there were 2 mitoses. On biopsy 3, there were 7, and biopsy 1, there were 10 mitoses. And it might be just a single case, but this shows us that it might just correlate what has happened inside the tumor with cellular density and mitosis at this point. So that's where we're going to start with the next trial or do, to say what we want to look for is, if you've suspected STS, soft tissue tumor, we want to do some functional imaging and tumor biopsies. And we want to decide who to allocate to chemotherapy or not, and say if you have a low ADC, which is an aggressive tumor, what we think is, or if you have an aggressive subtype, and some tumors are just not graded, as you know, or if aggressive grading, then you went for a high-grade STS, or you went for a low-grade STS. So what a pre-treatment assessment of biological aggressiveness is crucial for treatment locations of tissue sarcoma. Tumor heterogeneity has a major impact on treatment grading from biopsies, and routine pre-treatment assessment does not include functional imaging yet. Fusion imaging of preoperative imaging and postoperative computed tomography of resected specimen is feasible, and that what I show you was like a software for radiation oncologists. It's commercially available. A low site-specific correlation of histological and radiographic parameters. And the parameter we choose was apparent diffusion coefficient that seems to correlate with features of histopathological grading. And that is a candidate for radiographic grading in sarcoma, because radiologist says it's quite robust, even if you go to another machine or to another company that has another machine in the MRI. Thank you for your attention. And as I want to add is, most of that work was done by MD student Madeleine Hettler, who's based in Göttingen, but probably will move to Mannheim shortly. Thank you.
Well, thanks so much. That's just exciting. I think we all are struggling with determining the biopsy, because we base our therapy on the grading on the biopsy. And I'm just open the discussion. Hearing, listening to Jens and his proposal, what do you think? How do you think this will, where are the strengths and where might be the limitations? Well, maybe we start with the pathologist. Yes, please.
Yeah, well, that's our that's our pain and daily praxis and the daily suffering. So any method which could help you to get the biopsy. We can only diagnose what we see under the microscope, what we getting from the radiologist or whoever performs the biopsy. So whatever method gets you to get the proper piece of diagnostic tumor is of course very interesting. And well, that sometimes we also go for like if there is doubt, sometimes we do PET CT scanning and then go for biopsy from the kind of hottest spot. So it's probably something analogous or similar. Bernadette, what is your experience?
Yeah, yes, if there is any discrepancy between the radiology and the biopsy we have, the biopsy material we have, we say, let's give us another biopsy to be sure that we do not miss a high-grade tumor. But as you said already, we can only diagnose what we have under the microscope. And if we don't have enough mitosis or enough pleomorphism or necrosis to give a high-grade tumor. It's for us impossible. So it's a correlation between radiology and pathology, more or less.
As I might mention something, for example, in this huge tumor, Jens, that Jens showed us now, you can expect that the grade is higher than 1. So if I had a G1, I would do another biopsy to prove that there's a higher grade tumor in there.
I think it's fascinating too. Good. Yes, Jens, I think it's a fascinating tool. It's very useful in a practical setting. I think the next step probably is going to be a need of a large prospective cohort to investigate the prognostic value. And actually, I'm interested, of course, and everyone's interested in local disease and smaller disease in particular, because as it has just been said, we would expect here something which is quite bad, histologically speaking, but also in advanced phase. We'd be interested to look at the heterogeneity across metastatic sites, which sometimes is very puzzling with these slow growing metastases and so on. I think that's something which maybe you could want to test also on your data set, on a different data set, sorry.
Yeah, I thank you for that comment. We will probably head for localized disease next.
Yeah,
but
of course. Yeah.
Yes, probably yes, but I take it to my radiology team, I think. But the thing with the MRI is usually for the metastatic patients, we would use CAT scans for follow-up. And then I would have to look for something which would be similar to what we use right now. Because the functional imaging we use right now is just MRI based and not CAT scan based. So that is, and we usually don't use like a PET CT for that, usually not.
Great. Any further comments? Then I think please, Shitaro.
Yes, congratulations for your very interesting study. And I would ask you that, so is there any discrepancies between the subtypes of the tumor, like you demonstrated the leiomyosarcoma, and how about more pleomorphic sarcoma or myxoid lipo, maybe very uniform, but is there any discrepancy between the subtypes?
We don't know yet. I'm sorry. We just a whole bunch of histologies inside because we just started to take more or less any tumor we could get in the beginning, and so we don't have any robust statistics. But I would expect that it ends out like, for example, in SFTs, there have been quite some cohort trials shown that cutoff for higher and lower risk tumors is different from what the FNCLCC grading shows. So I would expect that there's a difference in the histologies. Yes, I would expect that. Yeah.
But we would, of course, the pathologists would comment on it if it's a SFT. So so usually we get the diagnosis of SFT if this is a differential diagnosis pathologist. But sometimes, as we discussed it in the differentiated like chondrosarcoma. So if you have a pleomorphic sarcoma and then the next biopsy contains some cartilage, or if the next biopsy from soft tissue tumor contains pleomorphic lipoblast, we could change the diagnosis. Yeah, that's true also for the subtyping of a sarcoma, not only grading.
Bruna, you also wanted to comment?
No, it's a question about the methods. So just use it the MRI, but it could be any correlation between maybe the scan and also the MRI. I mean, just to make things more cheaper, let's say. Or no, you just test it with the MRI and you are keeping going on that.
Currently we will stay with the MRI. I mean, there are from the London group or from Chris Matthew, there are some works on how to judge retroperitoneal sarcoma, or to at least judge the amount of necrotic tissue in that tumor. And even for the STRUSS-2 trial, there's inclusion criteria. If you can't achieve a grade 3 liposarcoma, but you find some necrotic tissue on the CAT scan, you can include the patient. And that is very consequent use of what you see in imaging. If you like, Amandine Crombé is another radiologist from France who did a lot of work on these functional imaging issues. And she also worked with pleomorphism on MRI and with the definition of the amount of more or less necrotic tissue inside. So this is probably overlapping. And we have to find out which to choose in the end. But I think the clue is especially to have some prospective data on there where you use some robust methodology, because if you look at MRIs, and we looked like backwards in more than 100 MRIs from different patients, if you send them to another institution, you just get a whole bunch of different sequences, and they are usually not comparable, and that is the most difficult part about functional MRI in that part.
Okay, great. I think we have to move forward. Thanks so much. Great contribution. Now I'm really happy to introduce Bruna David, who is right now in Costa Rica and shares an interesting case for us. Please.
Okay, so first of all, thank you so much for the invitation. It's a great pleasure to be here. I'm Bruna David from Brazil. Actually, I'm from Rio de Janeiro. I'm not from São Paulo. I just saw the sign with São Paulo. I'm from Rio. And I'm a medical oncologist here, there in Brazil. So my case presentation is a super real life case from underdeveloped country, let's say. So you can criticize as much as you think, because sarcoma treatment in Brazil until now is a mess. So we are trying to improve it. It's a female, 39 years old, no comorbidities, no family history of cancer. And she started her history in another institution. September 2017, due to abdominal pain, the patient underwent to a CT scan that showed intrauterine mass of almost 11 centimeters. It was diagnosed radiologically as submucous leiomyoma. A biopsy was proceeded, and we understood from the pathology report that it was a morcellation, and the report was leiomyoma with hyaline degeneration. After this biopsy versus morcellation, the hysterectomy was proceeded, and the pathology report was well circumscribed mass sectioned. So first the morcellation, and after this surgery with the tumor in pieces. The report was a uterine leiomyosarcoma, high grade 1. And yeah, here I want to make a comment, which is I don't have the pictures of the first pathology because the patient was treated in another institution. And here I have my first question. If you can put to vote. Yes, thank you. Please vote. How do you want to proceed after this first history of morcellation and tumor section? Okay, so the majority wants adjuvant chemotherapy. Okay, and after adjuvant chemoradiotherapy. Okay, I'll leave the comments about treatment of leiomyosarcomas from uterus for the end of my presentation, okay? So you can comment as much as you can. So they decided for follow-up, and 1 year later, September 2018, the patient presented with the lung progression, oligometastatic disease, and the metastastectomy of 2 nodules was proceeded. The biggest one was 1.2 centimeters. And it was metastatic uterine leiomyosarcoma. And at this time, she was proposed to adjuvant chemotherapy with gemcitabine and docetaxel. She completed the 6 cycles under a clinical toxicity, which she relates super hard for her. After almost a year, again, a new recurrence in pelvis, this time 11 centimeters mass, and the tumorectomy was proceeded, and it was again a leiomyosarcoma. And at this point, she came to our institute. It was her first visit. I forgot to comment, this is not a case of mine, it's a case of a group of colleagues. So I didn't see this patient at this time. And after this tumorectomy, she had this small nodule in the PET CT. So as you can see here. And what would be your next procedure? Just to remind you, uterine leiomyosarcoma, morcellation, section of the tumor, and gemcitabine docetaxel as adjuvant therapy in this progression. Okay, the majority went for neoadjuvant chemotherapy. Okay, we also went to a neoadjuvant chemotherapy, 6 sacks of doxorubicin ifosfamide. We can comment about these schemes of chemotherapy later, please. And January 2020, a new resection, an extended one, and no viable neoplasm was seen in this specimen. So also the NTRK PD-L1 and microsatellite stability was tested, everything was negative. So after almost 2 years, the patient was under clinical follow-up after the chemotherapy and surgery, and a new progression was seen in the lungs. Pulmonary progression and bilateral iliac fossa. She refused the chemotherapy due to the toxicity that she experienced before with gemcitabine and docetaxel, and also with the adramycin and fosfamide. So we decided to go to gemcitabine and the carbazine due to the toxicity, and after 1 cycle, she wanted to stop the chemotherapy due to, again, toxicity. So more or less 3 months later, May this year, new progression in the pelvis and symptoms of intestinal semi-occlusion. And at this point, the patient wants to go to chemotherapy again, but she has a poor performance status. We don't have trabectedin in Brazil, and pazopanib was denied by the health insurance. And this is the new recurrence disease. So what next? We don't have trabectedin, pazopanib, and we have a few options to treat this patient which has a poor performance status. So please vote. Okay, the majority wants high-dose ifosfamide. Okay, I move to the case again. And we decided after a multidisciplinary discussion to go to radiotherapy with the lattice technique. I know that we have many radiotherapists here, so I want to hear your thoughts later. I won't discuss about the doses because I'm not a radiotherapist, so you can tell us your thoughts. So the point is the patient underwent radiotherapy with the side effects of nausea and diarrhea grade 2. So she underwent super well. These are the images of the plans before the treatment. So here is the mass in the lung, the abdominal mass, and these pictures for the first necrosis that she has in the beginning of the treatment of the first phase of lattice. And this is the response. So this is the lung after the radiotherapy. This is the lung before chemotherapy, radiotherapy, I'm sorry. So this is the mass after radiotherapy. These images are from last month, so September. The radiotherapy was in May. So just to give a comparison, and this is May and September. So just to make a comment about this radiotherapy scheme, let's say, You used to treat this kind of patient with radiotherapy due to symptoms relief, but at some point you can gain also some response and performance status with this kind of improved responses with new techniques. Not new, but combining the techniques. So I want to hear your thoughts about this option. And nowadays the patient is performance status almost 90%, let's say.
Well, Bruna, thanks so much. It's really impressive. Basically, this is what we all want to achieve. Only surgery is better, right? But now I'm really looking forward what your thoughts are on that. Basically, on the radiation oncologist first. What's your experience with this technique, and how do you use it in your daily practice? Maybe Tom, do you want to start?
Sure, it's a technique that's been reported from the University of Maryland and from Washington University in St. Louis, and they interestingly have reported it for large sarcomas with interesting results. I personally don't have experience with it yet. It was done on studies there, and I don't know, Rick, have you had any experience with the lattice technique? I have not yet.
No, I have to admit that we don't have it. Not that I'm not a believer of the technique. It's called spatially fractionated radiotherapy. It is a promising technique. Probably in the next 10 years, we will hear more about it. There are some data on the immunogenicity of these tumors and the way they are treated by this form of radiotherapy, enhancing the antigen presenting features of a tumor like this. So it will be interesting to learn more about this technique in the future. For now, I think it's investigation. But congratulations on performing.
I learned about this technique from Gabi because you have used it for a few patients, and when I saw Bruna's case, I was all over. And Gabi, please share your experience.
Yeah, thank you very much, Bruna, for this great case. So to be honest, I'm a real fan of the lattice technique. We love it. We just treat the 20th patient right now. It's amazing, the effectiveness. And we have to confess, we don't know exactly how it works, but we can say it works. So we use it for the, as you showed us, for the big masses, for the palliative situations, and patients tolerate it very well because the hot spots are in the tumor mass, so basically no problem. And we saw in all patients a clear benefit, which was higher than to expect from the general dose to the tumor mass. So it's kind of magic.
Dr. Studer, can you comment on what your definition of effectiveness is? Can you allude that to the audience?
When you give 5 times 4 to a previously irradiated mass, and the thing is shrinking in a maybe half or so, then you can say it's not the just simple 5 times 4 gray. Cannot be when it's not reacting to 60. You know. So yeah, and basically all patients benefit from pain reduction. Yeah, so we are happy with this new kind of tool in quite desperate situations. And it's funny
Shintaro,
that this case.
Shintaro, do you use this technique in Japan?
No. This is the first time to see and hear the technique for me. But I never heard about to do this technique in Japan within my knowledge.
Philip, what about you in Vienna? Yeah, and Sean,
I have no experience with that. No.
Yeah. What about Jean-Yves? He's frozen.
No, I'm not frozen. Can you hear me?
Oh, here, great. Let me hear your face.
I don't see me for reasons which are unclear, but let's say, well.
But
we
no,
yeah,
perfect.
we looked at the at some publication. We have no experience. I think the case presented by Bruna is absolutely fascinating, and I'm going to rush to my radiotherapist just after this meeting.
So, but I gather that I mean, there's a lot of radiation oncology experience together now discussing, and at least there should be potential as you put it together, right? And it's something to follow up. That's very interesting. And I think the case is well, the one that you, Bruna, just presented is just spectacular. And I remember, let's say, a few cases from Gabi's experience, and that's really something for selected cases. I think this is really something to consider. Do you see any downfalls for that? Potential downfalls?
In favor of everything, provided you do it in a well-designed prospective study it and publish it.
Yeah, I think you just have to develop the appropriate treatment planning techniques for it, because you're putting very high doses, as Rick mentioned, in a spatial array, and you know, how it's best done. I think we're still learning it. Obviously, you have to take great care to make sure that the lattice hotspots aren't anywhere near appropriate or inappropriate normal tissue. But I think it's a very interesting technique, and as Rick Haas mentioned, we don't understand why it works, but it does not appear to be a classic radiotherapy mechanism. It may be enhancing immune recognition or other signaling pathways.
Would there be the possibility that, let's say, all those who are interested now here, particularly among the radiation oncologists, to team up and share thoughts, put it together, and let's say work towards such a trial?
Yes. Yeah, I read, I studied about this technique before, because I didn't know before coming back to Brazil. So I learned about this with my colleagues here. And yeah, there is some correlation between immunotherapy and lattice technique, because as you have the hot points inside the tumor, the peripheric tumor still has the immunogenicity and everything. So maybe the combination of immunotherapy and lattice could be something useful.
That's what we think. Would be great.
Yeah.
Would be very interesting. Yeah, yeah, and
yeah, there's some reports from Italy. I think 40 patients, something like this, with incredible responses. Super nice, super nice.
Mm.
But
and
may I have a question about the adjuvant therapy in this first scenario? Because most of the people vote for radiotherapy and chemotherapy in the adjuvant scenario of the morcellation. So would you go for that if you have a leiomyosarcoma from uterus after morcellation, or no?
Can I comment? The EORTC 55874 study was negative from the use of adjuvant radiotherapy in uterine leiomyosarcomas in a study that had 224 or something patients. Actually, in August of this year, SEER presented data on a much larger number of patients. Obviously, that's retrospective, but there seems to be a small gain by inverse probability of treatment weighting to see that the adjuvant radiotherapy actually does have some additional value in both overall survival and local control. Having said that, both NCCN and ESMO guidelines are negative for the advice of adjuvant radiotherapy in uterine leiomyosarcomas.
And what about chemotherapy after morcellation? Would you go for?
Well, it's an interesting question, but When I was trained in radiotherapy, it's now over 35 years ago, my professor would used to tell me radiotherapy is not a polish for sloppy surgery. Emulsilation is sloppy surgery. I'm sorry to say so. That's what it is. Jens, you're smiling.
Joanna and Joy, what's your opinion?
Sorry, did you ask me? I didn't hear it.
Just in this situation, the role of chemotherapy.
Oh, I would go, in this situation, I would go for adjuvant chemotherapy with doxorubicin and dacarbazine. We do it in these cases.
I think we did not hear Jean-Yves.
Otrobectedin.
Oh, delayed, maybe just delayed. Does that answer your
Can you hear
question,
me?
Bruna? Yes, now we hear you.
Would you go for adjuvant chemotherapy after morcellation and uterine leiomyosarcoma?
I don't know if you can hear me. Probably
Michael,
would
you
use
should
doxorubicin
switch on your
trabectedin in this case.
microphone.
I think we have some issues tonight with the tone. Jean-Yves, we don't hear you. Oh, again, can you repeat?
Michael, can you please switch on?
Yeah, well, in this.
Oh, it's Michael. Maybe.
Michael made some comments without switching on the microphone, but now perhaps you can repeat it. No?
If you really want to know that my son wanted to have a pizza, yes.
Oh!
That's good. Well, I think that brings us to an end. Michael and I, we were exchanging already, and we did not want to cut the discussion short because they are very interesting. And I think also just with Bruna's case, it just shows that it was worth exchanging on this topic. And Michael was kind enough that we postponed his case to our next MDT webinar, which will take place in February. And I think we are already looking forward for that. And having said all this, I learned again a lot today. Thanks so much. I think it's a tremendous experience that we can exchange all over the globe together with this high concentration of experience. That's a great addition. I cannot thank you all for the time that you take. And again, this will be available on video. And if you have any comments, please let us know. We are more than happy to improve. If you want to present cases on your own, feel free. We are more than happy. If you want to take or participate in the panel as well, the same thing. And we can exchange in the forum. So maybe just the questions to the panel. Any concluding remarks from your side?
See you next week in Vancouver.
Yes, likewise.
Yes.
Likewise.
Awesome. Well, thanks so much. I wish you a great day, evening.